Thank you so much. It's my great pleasure and honor to be here. I'm Dr. Ashikaga from Japan. Today's my talk is about the impact of the DCB success. At first, I will show that the market in Japan in the DCB. You can see the DCB strategy is more and more in Japan, and recently, 25% of cases were treated with DCB. And as for my Kasra, it's around 60% of cases were treated with DCB. And also, in Japan, we are doing with the image-guided PCI. 100% cases were treated with the image guide, and 80% cases IBERS, and 20% cases were treated with OCT guide. However, in my Kasra, 70% cases were treated with OCT guide. So today's my focus is clarification. You can see there in the long-term outcome of the severe calcified lesion is not so good. It's a worse long-term outcome, even with the CABG. So how about the point of the DES? It depends on the incomplete stent apposition and the stent expansion and edge dissection. It's a very high rate of restenosis in DS. This is our data. You can see there still we have much more restenosis rate in severe calcified lesion. 1 year is 10%, and 5 year is 30% of cases were TVF. So these are also our data show that what is the reason of the target lesion failure. And the point is a severe calcium, and hemodialysis is a very important point in relating with the restenosis with DCB. So how to overcome this calcified lesion and hemodialysis patient? So we have at first is you can see treatable calcified lesion is divided into 3 types. Top is non-eruptive, and middle is eruptive, and bottom is a superficial calcified seat, and mid portion is OCT, and right is IBERS. So we're using 4 types of debulking device. Not IBER is not debulking, but we're using 4 types of devices to overcome these situations. Japanese group show that rotational atherectomy has no inferiority of DES, and also they show that late lumen loss of DCB was less compared to the DES. This is our data show that long-term outcome of DES and the DCB after orbital atherectomy. You can see the event rate is similar, but the point is OCT data. Acute lumen gain is more in DES. However, the late lumen loss is more and more in the DCB group. And this is also, this year we show that the effectiveness of the IVL followed by DCB strategy. In the 1-year outcome, TVF is less than 10%, and this is acceptable data of the IVL. So I will show that the devices how to work of the superficial, non-eruptive, and eruptive calcified nodule. In the rotational atherectomy, you can see the guide wire bias plaque reduction, calcium reduction could be obtained. And next, OA can develop calcium with guide wire bias and far area by centrifugal force. And as for the excimer laser, this is only the saline flash technique. Superficial calcified lead sheet it's no effective. And the non-eruptive calcium nodule is also limited of effect. However, in eruptive calcium nodule, laser is effective. And with a guide wire bias. The point of IBL, it's superficial, is a very nice result, and also non-eruptive calcium nodule can compress and lumen gain could be obtained. And also, eruptive calcium nodule can get lumen gain compared to the cutting or scoring balloon dilatation. So the point is eruptive calcium nodule. You can see eruptive calcium nodule in clinical practice is three types, mainly in the ACS region. Sometimes it is a balloon uncrossable region. And we encounter some of the cases of a CCS region. Angioscopy show that like this is a pointed start. So previous reports show that eruptive calcium nodule has a long outcome, long-term outcome, despite acute stent expansion in DS. This is a case of data. It's a 73 CCS, hemodialysis and calcified nodule. You can see at first we are doing the OAS and cutting balloon and DCB is very nice result. However, 6 months later, he came back to the unstable angina, and we put the stent by using the excimer laser scoring balloon. And this is a very nice result of the DS. However, he came back to 2 months with non-STEMI. And also, we're doing the excimer laser again. However, in 1 month, he came back with STEMI. And then, finally, we sent this patient to the surgeon. Another case, this is also the 6-5 years STEMI HD. The culprit lesion is distal LED, and proximal LED, they have eruptive calcified nodule. This lesion also, we are doing the excimer laser followed by IBL. It's a good result. However, 1 year later, he came back with a reprotrusion of eruptive calcified nodule. We are doing the OAS, this patient, and scoring balloon and DCB is nice. However, 2 years later, he came back with the restenosis, reprotrusion of calcified nodule, and another osteal lesion. So we also sent to the surgeon. So how about the restenosis pattern after PCI with drug-coated balloon? This is a sub-study of our data. You can see the 3 types we have in the pattern of restenosis. One is a layered plaque, and the second is a suboptimal region enlargement. And finally is a calcified nodule protrusion. And also, this is also, we examined the eruptive calcified nodule, and 20% of cases restenosis in 2 years. And the point is, lesion with TLR is mainly with reprotrusion of the eruptive calcified nodule. So, last year's paper showed that some devices are using for the eruptive calcified nodule. You can see here the guide wire bias is in IBL is mainly 4 o'clock. And OAS is, you can see the 2 o'clock of the guide wire. The point, you can see in the bottom of the OAS, you can see some lumen gain could be obtained in the 4 to 8 o'clock. However, you can see with the guide wire bias, vessel injury occurred after the OAS. So we must pay attention to the guide wire position. It's very important because eruptive calcified nodule is mainly an eccentric lesion. So last year I showed that IBL, excimer laser, rotor, and OAS, how to work with the for the eruptive calcified nodule. We also show that previously the effectiveness of excimer laser, followed by the scoring balloon and DCB. However, this is only the case report. And we are doing some case with the rotational atherectomy or orbital atherectomy. And sometimes it's a very good result with the debarking device followed by the DCB. And the point is, eruptive calcified nodule sometimes is eccentric. You can see here, in the proximal site is guide wire position is very close to the eruptive calcified nodule. However, in the distal site is mainly to the normal vessel area. So we are using the OAS in the proximal and IVL for the distal. So the guide wire position is very important for the eruptive calcified nodule treatment. And plus, the additional scoring balloon is very important because in the calcified region, by using the scoring balloon, it's a round shape expansion could be obtained. So like this, and OCT, and sometimes by using the OAS followed by IVL, and it's not effective, and then plus IVL. And also, sometimes we are doing with the, this is the ostial RCA region, at first doing the OAS. However, after the OAS, you can see the guide wire position is very close to the healthy area. So I moved to the DCA for this patient. So we should pay attention to these devices. Depends on the guide wire bias or the reduction, a sonic wave effect, anti-predatory effect. Final message. Lesion characteristics dystenosis with DCB is a layered plaque, inadequate lesion preparation, and eruptive calcified nodule. And we are thinking about the get lumen gain is very important. So we must organize their strategy for eruptive calcified nodule is very important in the PCI era. Thanks so much.